to welcome our next speaker, Dr. Bandar Aljudaibi. He is a professor of medicine and chairman of the Liver and Small Bowel Health Center at King Faisal Specialist Hospital and Research Center in Riyadh. He is board certified in internal medicine, gastroenterology, and transplant hepatology, and is a fellow of the Royal College of Physicians and Surgeons of Canada. Dr. Aljudaibi is a pioneer in transplant oncology, having launched Saudi Arabia's first living donor liver transplant protocol for unresectable colorectal metastases and a frailty program at the University of Rochester. He previously served as the medical director of the liver transplant program at the University of Rochester Medical Center and contributed to the national initiatives in transplant oncology. He also served on the UNOS Region 9 Liver Review Board. Please welcome Dr. Aljudaibi with me to his exciting talk in transplant oncology.
Good morning, everyone, and thank you, Dr. May, for the nice introduction. And I would like to thank the organization for giving me the opportunity to talk about transplant oncology. I have nothing to disclose. These are my objectives for today, to go through the definition of a transplant oncology. But as a hepatologist, I would like to change the concept that it should be transplant hemato-oncologist rather than transplant oncology. I will go and expand about the indication of liver transplantation and transplant oncology. However, I elected not to talk about hepatocellular carcinoma because it's going to be covered by my colleagues. So what's transplant oncology? Gonzalez defined transplant oncology. He's one known surgeon from Toronto. Basically, it's the integration of a transplanter and an oncologist to push the envelope among patients with hepatobiliary malignancy, not only to improve their clinical outcome, but even in addition to enhance the research pipeline. But I'd like to challenge this concept. I believe Starzl started that concept a long time ago without naming it as a transplant oncology. If you can appreciate the first 7 cases that Dr. Starzl did, 6 out of them is related to malignancy, and as a matter of fact, 2 out of the 7 cases related to colorectal cancer and mets to the liver. As a hepatologist, we need to be in the front wheel with the oncologist and the transplant surgeon. This is an integrated model. We are the back corner of transplantation. We are very competent and comfortable in managing patients with advanced liver disease, whatever the cause of liver disease, but there is a paradigm shift. We have seen patients with advanced HCC who are on checkpoint inhibitors, and they come to us for transplantation. We are seeing right now patients with unresectable colorectal metastases who are coming for us for liver transplantation. We have seen as well patients with intrahepatic cholangiocyte carcinoma that used to be a contraindication for liver transplantation. They are coming to us. So the paradigm and the future is bright for us, not only from clinical perspective, where we see there is an expanding indication for liver transplantation, but there is an opportunity of translational research. We can perform pharmacogenomic studies. Why patient X responds to chemotherapy, whatever it is, and there is a patient Y who's not responding? Why there is a partial response? Do we need to use liquid biopsy? What's the utility of the liquid biopsy? Can we come with a predictor of a tumor recurrence, whatever the cancer is the patient was transplanted for? What's our role as a hepatologist in adjuvant and neoadjuvant therapy? How can be integrated in the model with the tumor board where we have the oncologist and the transplant surgeon? What's our role as a hepatologist post-liver transplantation to decrease the tumor recurrence? Shall we use mTOR inhibitors? Shall we minimize FK and MMF? Shall we use liquid biopsy frequently post-transplantation? These are questions that haven't been answered, and this is for us to lead the field and answer them with the support of the surgeons as well as the oncologists. So let's start with colorectal metastases. This is a study from the state, although the registry in Saudi Arabia, I believe there was around 3,000 to 4,000 cases of colon cancer with mets to the liver. But look at the data from the state. In 2021, 151,000 diagnosed with colon cancer. Unfortunately, 50% of those patients, they present with liver metastases at the time of diagnosis. If you look at the figure A, you could see that the incidence of colon cancer has been decreasing in the older population because of the robust screening program. But unfortunately for the younger generation, it's on the horizon because we do not have a robust screening program for them, and who we should be triggering as a high potential risk of developing colon cancer in the future, they need to be screened. Paul Dack from Norway changed the mindset of liver transplantation for patients with unresectable colorectal mets. The study is from Norway. It's a pilot study of 21 patients. Those patients underwent primary resection of their tumor, the primary tumor in the colon, followed later on by liver transplantation. And you can appreciate in the red line that the overall survival at 5 years is around 60%. As a benchmark in the transplant society, a 5-year survival of 50% is acceptable. You may argue with me we should push the envelope even farther, that it should be no longer the case 5-year survival of 50% is acceptable, but let's take that as a granted. 5-year survival of 50% is acceptable. It reached the target, although it's a pilot study, is at 21 patients. But if you look at the gray line, the disease-free survival, all of the patients had a cancer recurrence post-liver transplantation at 2 years, but at 5-year survival is 60%. We'll explain later why. But in this small pilot study of 21, they came with the Oslo score to figure out who are the patients who will do well post-liver transplantation compared to the patients who will not do well. So what are the parameters what are the scores they look at? So it's a cumulative point by each characteristic in that table. So if the tumor diameter is more than 5.5 centimeter, patient will be given 1 point. If the pre-transplant CAA more than 80 microgram per deciliter will be given a point. If there is a progression in chemotherapy, that means the cancer did progress, that's a point. And the time interval from diagnosis to transplantation, if it's less than 2 years, this is a point. So if you look at the figure in the left, the red line, okay, those are patients who has Oslo score of 0. At 5 years, they've had 100% survival rate compared to patients with Oslo score of 4. It's a promising, but you need to take it with caution because it's a pilot study of 21 patients. But it opened the light for those patients. It did open the hope for those patients with unresectable colorectal metastasis that transplantation is an option. You just said a minute ago that all the patients has cancer recurrence after liver transplantation, yet they survive longer. What is the case? Why is that happening? Well, because most of the cancer, when it comes back to the lung. Can be resected. It can be treated with SBRT. And usually it's an indolent disease. It progresses slowly. It's a different animal than hepatocellular carcinoma. However, if the cancer comes back to the liver, usually it's a poor prognosis. It has been debatable in the society, even with Poldak paper, whether or not liver transplantation should be an option for unresectable colorectal mets until we have the first randomized trial transplant study by Rennie and his colleagues. Patients were randomized with unresectable colorectal mets either to go for chemotherapy followed by liver transplantation or the standard of care chemotherapy alone. And you could appreciate at 5 years survival of 73% among patients who underwent liver transplantation compared to the standard care therapy is 9%. And even the progression-free survival, it was superior among the group who underwent liver transplantation compared to the group who just had the standard of care therapy of the usual FOLFOX or so on. We launched a survey. When we launched the project first at the University of Rochester, the transplant study has not been released. So there were a lot of ethical questions whether live donor liver transplantation could be an option of those patients because we're very strict and regulated in the state. We're heavily dependent on cadaveric organs, so we want to open the pipeline for those patients with unresectable colorectal mets that they could benefit from liver transplantation through a live donor. So we said, well, it's not for us to say. We say that the literature is there. It's a positive vibe that we could proceed, but we want the society to answer us if this is something acceptable we should embed it in our practice or not. So we sent the survey and we got 500 responded for 3 cases. So the first case we said, okay, let's ask the society or the community throughout the country whether genetic disease is considered acceptable to proceed with live donation. We made the assumption that most likely the people or the respondent will be a positive vibe. Then the second scenario, whether or not you consider to transplant a patient or to donate to that individual with a history of alcohol-related liver disease who have been absent for at least 6 months. And the third scenario, if you know that the person you're going to donate your liver to had a 50% chance of disease recurrence of the colorectal mets, would you consider donating? I mean, this study may not be applicable to the Middle East because our mindset with live donation is different from the West, but it was worth to put the survey out and see what's the response. So we got 49 respondent. Most of them are Caucasians. Most of them are well educated and they know about live donation, which could be a bias. But you could appreciate that 70% of the respondents say yes to donate for colorectal metastases. It was higher compared to if the indication was for alcohol-related liver disease. And it's not surprisingly, genetic predisposition was actually the dominant in the response. So we launched that protocol with the support of the group at King Faisal Special Hospital. We looked at several protocols. We looked at POLDAC protocol. We looked at the Rochester Gonzalez protocol, and we modified them to our need. So basically, what's our inclusion criteria to consider patients for liver transplantation for unresectable colorectal metastases? The patient needs to be adult, above the age of 18. The primary tumor needs to be resected, or we can plan it for the future for the primary tumor to be resected. They need to have a disease stability for 6 months. We feel very comfortable if the colon cancer in the left side compared to the right side. If the cancer is on the right side, you need a little bit longer duration of time to wait before you subject the patient for liver transplantation. A CAA level less than 80. BRAF is being excluded, but the rest of the genetic makeup is fine. And it's a must that they have an Oslo score of 2 or less. Having said that, if the CAA more than 80, they will be excluded from liver transplantation, or if there is a tumor progression on chemotherapy, they will be excluded as well for liver transplantation. So where we're at, this is kind of a little bit outdated slide, but in total we have a 25 referral for the consideration of liver transplantation at King Faisal Special Hospital for unresectable colorectal mets. 13 patients accepted in the pathway. The pathway may go up to a year and a half. We transplanted so far 4 patients with unresectable colorectal metastases. 9 patients have been discussed on a regular basis every 3 months at the MDT. Unfortunately, 7 were declined, whether due to tumor progression or maybe actually the surgeon found out that it is a resectable disease from the liver, so they did not need to go for liver transplantation, which is still a positive thing for the patient. This is another paper that we published with Roberto Hernandez. What we looked at the explanted liver. So during the MTD rounds with those patients with unresectable colorectal mets, while we are heading to transplant, 60% of who had complete radiological response based on the MDT and based on the radiologist where they cannot see the tumor. Actually, they have a tumor in their explanted liver. So the message from that, don't be fooled that, okay, they achieve complete radiological response while they are on a maintenance therapy, whatever the maintenance therapy is, whether it's a 5-FU cetuximab or a second-line therapy, they still have cancer. They will benefit from liver transplantation. Moving the wheel from colorectal cancer to neuroendocrine tumor. Neuroendocrine tumor frequently metastasize to the liver. 50% of the patient will have mets to the liver at the time of diagnosis. Historically, the 5-year survival is 30%. Surgical resection of the primary tumor is considered to be curable as long as there is no peritoneal deposit. And several cohort, the 5-year survival is between 60 to 80%. And unfortunately, not all the patients are candidate for surgery. Prof. Mazzaveru, the pioneer not only for the Milan criteria for HCC, but even for neuroendocrine tumor. And this is a prospective cohort of a follow-up of 10 years with neuroendocrine tumor. He looked at 2 cohort patients who underwent liver transplantation with neuroendocrine tumor versus patient who had no liver transplantation. It could be surgical resection, medical therapy, and so on. And you can appreciate the 10-year survival is superb among patients who underwent liver transplantation. But hold on, not all the patients with neuroendocrine tumor will benefit from transplant. There's a selective criteria. They need to have a favorable tumor biology, grade 1 or grade 2 with low Ki-67 and mitotic rate. They need to have a tumor burden of less than 50% in the liver. The primary tumor needs to be resected and to be drainable through the pancreas or the small bowel to the liver. And they need to have a disease stability for 6 months. The age cutoff of 60, this is a relative contraindication. However, this has been modified and been taken off from a lot of society, including the OPTN. Age 60 is no longer contraindication to proceed with liver transplantation for neuroendocrine tumor. And this has been adapted by the OPTN in the state and a lot of society throughout different countries that it's acceptable to proceed with liver transplantation for neuroendocrine tumor. Professor Mazaver looked at the data in a different way. He said, okay, well, in the first study that I showed you, the comparison is liver transplantation versus other, which could be surgical resection, systemic therapy, and so on. In this study, he performed a retrospective analysis, a prospective study comparing two groups, liver transplantation versus surgical resection. And you still can appreciate that the overall survival and disease-free survival is superior with liver transplantation compared to liver resection. But there is a very important point to keep in mind here. As I stated, you need to have a disease stability for 6 months, so you have time with you. Similar with colon cancer as well. You don't transplant it immediately. You have the time. Time is your card to differentiate the patient who has a good tumor biology from a bad tumor biology. With liver resection, the surgeon will not say, I will wait for 6 months to perform a surgery. I will take the patient immediately for liver resection, where with transplantation, you need to wait for 6 months. So you could see there's an advantageous, the time advantageous with liver transplantation, that already you exclude people who have bad tumor biology, and you only transplant the people who has a good tumor biology. With liver resection, it's a lump sum for everything, bad and good tumor biology. And with the evolution of PPR therapy, that may change our concept for liver transplantation for neuroendocrine tumor. It may be people who has a favorable tumor biology with neuroendocrine, they may not need a transplantation in the future. We'll never know. They may be maintained on PPR therapy indefinitely. And maybe the people who we used to exclude for liver transplantation for neuroendocrine tumor because they have a bad tumor biology, with the PPR therapy, we may bring them back. And we have seen this paradigm with HCC. Moving to intrahepatic cholangiocarcinoma. Cholangiocarcinoma in general, as a hepatologist and as people in the community that dealing with liver disease, is the second most common primary hepatic malignancy after hepatocellular carcinoma. The incidence in the horizon, whether because of the acknowledgement or because we have a better imaging modality or because of both. Unfortunately, a lot of patients may come with unresectable disease, and the 5-year survival is suboptimal, is around 30%. And historically, liver transplantation for intrahepatic cholangiocarcinoma is considered to be a contraindication until recently, and I'm going to take you through the data. Gonzalo performed several retrospective center studies looking at patients who underwent liver transplantation without knowing that they have intrahepatic cholangiocarcinoma. So the thought it could be maybe HCC before liver transplantation, or incidental finding of intrahepatic cholangiocarcinoma that was discovered after transplant. And he looked at two groups. He said, okay, let's look at the group of intrahepatic cholangiocarcinoma of 2 centimeters and less. This is one group. The second group is patients with intrahepatic cholangiocarcinoma of 2 centimeters or bigger or multiple. And look at the overall survival and recurrence-free survival. And as you can appreciate, patients who has an early intrahepatic cholangiocarcinoma of 2 centimeters or less, they have a better overall survival with lower recurrence of the disease post-liver transplantation. So that was kind of an insight that, well, maybe we can transplant patients with intrahepatic cholangiocarcinoma, and if the lesion is 2 centimeters or less, patient will still do well. But Mark Gabriel from Houston pushed the envelope. He performed a study prospectively, patients underwent liver transplantation for intrahepatic cholangiocarcinoma versus liver resection, regardless of the tumor size. The largest tumor diameter was in the transplant group, around 11 centimeters in size. CAA was more than 100. There was a vascular invasion, but they need to have disease stability for 6 months in chemotherapy before subject them for liver transplantation. So that was a mind changer, that the overall survival, even among those patients with intrahepatic cholangiocarcinoma who has stable disease for 6 months, is more than 50%. Again, the studies has been critiqued. We need to have a better predictor. We cannot subject everyone for liver transplantation for intrahepatic cholangiocarcinoma. Maybe the liquid biopsy will help. Maybe we need to have a better modulatory therapy, immunotherapy, and so on. But the concept is, those patients have a hope. Yes, if you select the right patients, and time is your card to wait for 6 months to eliminate the people who has a bad tumor biology versus the patients who has a good tumor biology. So if the patient had an intrahepatic cholangiocarcinoma that is resectable, by all means, they go for liver resections. If it's among cirrhotic patients or patients with PSC where the surgeon would be concerned to take them for surgery, then Systemic therapy might be an option followed by liver transplantation, or it could be local original therapy as well an option if it's a solitary lesion.
1 minute left.
So I'll skip some of the slides. Hyalocholangiocarcinoma has been validated as the protocol has been established by the Mayo Clinic and then has been validated after that with multi-center prospective study. There is a specific protocol, again, the rule of 6 months applied to most transplant oncology patients to eliminate the patients with bad tumor biology. Durvalumab is no longer a new therapy, but it has shown an overall better survival when it's used with Gemcitabine compared to the standard therapy among patients with intrahepatic cholangiocarcinoma. And the future is bright. For patients with hepatobiliary malignancy, there was a lot of prospective randomized studies looking at different type of therapy, different modalities. So we'll be seeing more of those patients coming to us for the consideration of liver transplantation. I would like to say, yes, transplant oncology is a well-established concept, but I would like to push the hepatologists, all of us as a community. We need to be in the front line with our colleagues. It needs to be done through a multidisciplinary approach, through a specific protocols throughout the country, because we don't want, actually there's a paper published in the state where each center, they're doing their own thing, and unfortunately the data, the outcome was poor when they used the cadaveric organs. So we need to be very mindful. And again, what matters in terms of outcome is the biology. If we can figure out the biology, we'll serve our society well. Thank you.